All right. Well, thank you for joining me this afternoon. Thank you for taking time out of your busy schedule. My name is Edith Johannes. I am a nurse practitioner at UCLA Health in Los Angeles, California. I have been working with liver disease patients and liver transplant for approximately 17 years. And I have one big disclosure, and that is that I really enjoy talking about the liver. So bear with me. I'm happy that you're here. I want to also thank GHAPP and Madrigal for putting together this community network to talk about MASLD and learn how to diagnose it. If you don't know what MASLD is, then you are in the right place. This is a session geared to talk about the very basics of MASLD and how to diagnose it. I have added my email here in case you guys have any questions or you have any feedback for me. I'm happy to try to answer questions and would love feedback from you. This is the QR code for registering for the session if you haven't already done so. I also want to say that GHAPP does have a lot of free educational material on hepatology and also in GI topics. So please check that out. I also want to thank Madrigal. If you have any specific questions about MASLD, MASH, and treatment options, this is a great website here. So this is a QR for that. I encourage you to seek that out. The first thing I want to say about MASLD and MASH is that it's gone through some changes, and this is a new name for this disease process. It used to be what we called NAFLD and NASH. NAFLD stands for non-alcoholic fatty liver disease. In NASH, it was non-alcoholic steatohepatitis. There was a lot of rumbling around the titles of this disease because patients stated that they felt a high degree of stigmatization because of the words alcohol and the word fatty being in that title. There were some studies showing that patients were less willing to talk about the disease process and seek medical care. And this change came about from years. And in the last 3 years, from 2002 to 2003, there was a consensus, and the new name became MASLD, which stands for Metabolic Dysfunction-Associated Steatotic Liver Disease. Now, one thing that I want to say is that there is an overlap in all the diagnoses and studies and treatments between MASLD and NAFLD and MASH and NASH. So all of the guidelines that are out there for NAFLD and NASH are applicable to MASLD and MASH. Just want to make that distinction there. When we talk about steatotic liver disease, I want to say that it's a big umbrella. Steatosis in the liver can be from many different things. So when we talk about steatotic liver disease, we have to think of it as a wide range of diseases that are causing this. The main component is that there is fat being deposited in the liver, within the liver cells. We then need to figure out whether this fat deposition is related to a metabolic dysfunction or anything else. And that's really what we're doing here. It can be deposited by drugs. So you will have like drug-induced liver injuries. You can have viral hepatitis. You can have alcohol alone cause steatotic liver disease. So it's important to make sure that we distinguish between any of these diseases. And if none of them are there, then we're leaning towards it being a metabolic dysfunction. Now, there is sometimes an overlap, and this overlap happens many times with patients who meet all the criteria for MASLD, but then they tell you that they're also drinking. And then when they tell you they're drinking, they're like, well, I drink a little or maybe a little more than a little. So figuring that out is very important. And I'll come back to the slide because this middle part of this middle area here is very important when we talk about figuring out how much somebody is drinking. In order to diagnose somebody with MASLD, we have to not only identify that they have a steatosis, but we also have to identify that they have cardiometabolic risk factors. These cardiometabolic risk factors include 5 things, and you only need one of them in order to meet criteria. And these things are having a BMI that is high. It is a little different if you're a male or a female. The BMI is different. And it's also important to know that for the Asian population, the BMI is a little bit lower than it is for the rest. So BMI being greater than 25, waist circumference being high, 80 centimeters for men, 80 centimeters for men and 94 centimeters for men and 80 for females. Also, fasting glucose, if it's high, hemoglobin A1C, if it's greater than 5.7, or just having a history of type 2 diabetes would count. Having hypertension and being treated for it, having high triglycerides, and having a low HDL. I say having hypertension or being treated for it because sometimes patients will claim they don't have hypertension, but then they are on an antihypertensive. So this is just to help them understand that part. If you have somebody with steatotic liver disease, the next thing to do is to look at the metabolic criteria. And if they have even one of these criteria, then we would lean towards diagnosing that patient with MASLD. But again, I'm going to say this like 10 times throughout this talk, is that it is very important to rule out all the other causes of steatosis. I'm back to the slide because I mentioned that the middle slide that talks about that overlapping diagnosis is important. The reason it's important is because you have a patient who may have metabolic abnormalities and also be drinking, but we have to distinguish between how much they're drinking. If this is a disease that is predominantly alcoholic in nature, then we are going to be guiding them for treatment in a different pathway than if it's really just metabolic dysfunction primarily. So differentiating what the predominance is, whether it's alcohol or MASLD, is important. Now, the way we decide what is predominant is based on how much a patient is drinking. Now, this is a loaded question because when we ask people how much you're drinking, we tend to hear vague statements, right? They'll say, I have 1 drink a day, or I have 2 to 3 drinks a week. But we all know that we need to be a lot more specific in that. And we get down to the nitty-gritty, right? We are asking specifics of like, how many grams are you drinking? So you have to ask questions like, what exactly are you drinking? Are you drinking beers, whiskey, or mezcal? And how often, and what size is that drink that you're drinking? So very, very specifics. When they look at grams, they look at it in weeks or on a daily basis. So if somebody is having 2 beers, then there's approximately 14 grams of alcohol in every beer. If they're having 2 beers per day, then you would look at the bottom area here and then calculate to see where they're at. It is not very much alcohol for them to kind of be leaning towards a more alcoholic liver disease predominant stage. Okay, so this is one big distinction here. Now, patients usually come to primary care with vague complaints. They'll have a complaint of abdominal pain. And let's say that you have looked at their symptoms and their labs, and you are concerned that they have MASLD. You've checked for different things and they meet criteria for MASLD. And the next step would be to understand whether there is actually some inflammation happening within that liver. We want to know if the inflammation is causing any damage. So there is a difference between saying somebody has MASLD, which just says that they have a metabolic dysfunction and fat in the liver, And a big difference is they have some inflammation going on, or if the inflammation is already causing some damage, which would lead to fibrosis. And if they are having fibrosis, then how much fibrosis do we have, right? So it is a progressive disease, and all these patients are going to be at a different stage in that progression. So one of the easiest ways in primary care or in specialty clinics for that matter would be to obtain a FIB-4 test, which is a lab test that is a calculation that uses ALT, AST, platelets, and the patient's age. And it comes back with this number. And this number gives us an idea of how much damage there is to the liver, if any. If the FIB-4 is less than 1.3, then they fall into the category up here where it's very unlikely that they have any fibrosis at the moment. And you would want to tell those patients that they can work on lifestyle modifications, but you want to not forget about them. You want to bring them back between 1 to 3 years, depending on their risk factors. Having diabetes is a big risk factor, so I would want to see that patient within a year and run the FIB-4 again and see how they're doing. If they have no risk factors at all, then maybe you can extend that to a little bit longer. It makes me nervous to wait up to 3 years, so I usually say 1 to 2. Now, if the FIB-4 comes back and it's super high, and I'm just going to click through these so you can see the number, as high as 2.67, then that actually makes it kind of easy for us because we say, you know, you seem to have a lot of damage to that liver and fibrosis, and we really need to get you in with a specialist, which would be a hepatologist, to look at the degree of fibrosis slash cirrhosis because it's pretty advanced. So we want to send those people to hepatology. The difficult area is when you get a FIB-4 and you're kind of in between. You know, you get a FIB-4 that is greater than 1.3, 1.3, but it's not quite the 2.67, right? So you're like, so then you think, well, what do I do with this patient? This is a little bit harder one. So when we get these patients, you want to recheck other tests that were going to help you to identify how much inflammation there is within the liver, help you to identify if there is a lot of fibrosis. And you can do this by doing things like an ELF test. And this is an enhanced liver fibrosis panel. And it includes things like collagen and hyaluronic acid and some inhibitors. And what it does, it kind of gives you an idea how much fibrosis is going on, right? And again, if the result comes back and it's pretty high or pretty low, it's an easy decision. You continue to monitor or you send them to hepatology to get cirrhosis management. But if it's within the middle range, it again leaves you with not knowing what to do. Same thing happens with the elastography. Elastography is a test that is usually vibration based, or you can have an ultrasound that has waves that go through the liver and it gives us an idea of how much fibrosis there is. But again, if the results are indeterminate, this is when it's a little bit hard. And when that happens, this is the time when we say that you want to send them to hepatology for further workup and a liver biopsy, because finding out if somebody has severe fibrosis, like at stage 4, is very important. The reason why this is important is because it will completely change the way you take care of these patients. If you have somebody with a stage 0 to 1, which would be no fibrosis or minimal fibrosis, you can work on lifestyle modifications and continue to monitor. If you have somebody in stage 4, again, they may need a liver transplant at this stage. But if you have somebody with stage 2 fibrosis or stage 3 fibrosis or somewhere in between, we need to work on lifestyle modifications in addition to possibly starting pharmacotherapy. There are studies showing that fibrosis in this stage 2 and 3 with lifestyle modifications, pharmacotherapy, fibrosis regresses. So fibrosis at one point in the past was thought to be stagnant. You know, once you were at stage 2, you just move forward. That is no longer the case. Studies have shown that you can regress in that disease pattern. So although it is progressive forward, it is regressive as well. And this is what's more important to catch. We want to catch these patients that are in stage 2 and 3 before they ever get to stage 4. Okay. So why is it that I've been getting more and more interested in talking about MASLD? Well, because it's booming, and it's booming not in a good way. It's becoming the most prevalent reason for liver transplantations to happen. It's estimated that in North America, there's about 30% of the population who has MASLD. And in Latin America, it is the highest. It is almost 45%. And that kind of hits me directly. So I think this is why I've gotten more interested. The progression of MASLD is also pretty dire. About 60 to 80 million Americans have MASLD, and about 25% of those have MASH, which means they already have a degree of hepatitis. They already have a degree of inflammation and injury going on. About 25% of those will develop fibrosis within the next 3 years. And from there, 20% of them will develop cirrhosis. Once cirrhosis develops, some people unfortunately progress very quickly, and there is a very high mortality risk, about 30 to 40% mortality. And then some of them progress a little bit slowly, and you see them go through liver failure at a slower rate, but then may require liver transplantation. I think another point that is very important to make in this slide is that you don't only have fibrosis, cirrhosis, and perhaps failure, but there is a chance of developing hepatocellular carcinoma from the simple fact of having MASLD and MASH. There is no necessity to have fibrosis in order for you to develop cancer in the liver. Cancer in the liver can develop with just simply having inflammation and fibrosis. No cirrhosis is required. And that's important to note. This is another slide that I like because it looks at the progression of the disease, and it starts out by showing us a very healthy liver, the tissue is nice. And then it shows you how it progresses with the fat deposition and then the fibrosis and into cirrhosis. And HCC is at the end, but honestly, it could be all the way throughout the entire outline here. One thing to note about the slide, though, that I want to mention is that they have found that there are some genetic components that affect MASLD, and it makes MASLD develop faster, and it makes MASLD develop more often, right? And the population that has been noted to have a higher prevalence of PNPLA is Hispanics. And again, that becomes interesting to me because of my background. So this is very interesting. So I want to say that with your Hispanic patients, if they have any risk factors and you're not sure whether they have steatosis, then start thinking about it. Keep that in your mind that they may. In this slide, the one thing I want to mention is that the rates of fibrosis progression has a lot to do with where you start in the disease, where you get diagnosed. Of course, if you get diagnosed at a stage 3, then you may progress a lot faster than if you were caught at stage 1 fibrosis. But also the genetic factors influence, and also your lifestyle has a lot of influence, and comorbidities do as well. Okay. So now that we've learned everything of MASLD and how to diagnose it, I'm going to apply this to a patient that you may encounter in primary clinics or in any other clinic for that matter. And things that you would notice is that this is a Caucasian male. He's 55 years old. You can see by his picture that he does look a little overweight. And that gets confirmed when you check his BMI and it comes back as 35. His only complaint when you see him is that he is having a little bit of right upper quadrant pain or discomfort. He tells you that he's been gaining weight in the last 5 years. And as you're talking to him, he tells you, yeah, I've gained almost 20 pounds. And you have some labs available, and the labs, they have an ALT of 45. Well, it's high, but it's really not too high. So sometimes these numbers don't really, there's no like red alarms going off when you see this. But when you start talking to him a little bit more, you do find out that he does have a history of hypertension, and his hemoglobin A1C is 6.3. So there are some of your risk factors already present here. He tells you that he does drink alcohol, but it's pretty rare. And he works in IT. By working in IT, well, most likely it's kind of a sedentary job, and he doesn't mention that he's doing any hobbies. So we have to consider lifestyle here too. As far as the rare alcohol consumption, we don't know what that means. Rare for him could be, every other day. I don't know that. So this is important to note and to really talk a lot more about. But for the purposes of our basic dialogue on MASLD, we're going to take it at face value and say that he drinks very, very rarely. And this is something that is not affecting our discussion at the moment. He is on lisinopril, so we know that his hypertension is being treated. And when you see him, you do notice that he has central adiposity. So most of his fat is in the central area. Okay. So I was going to ask you before I move to the next slide whether, well, do you think this patient actually meets criteria to diagnose him with MASLD? And I'm seeing some head movement. And I would say, yes, he definitely does meet criteria for diagnosis of MASLD, but I want to go back to basics and remind you that even though we have a patient that we see all the criteria met on our history and our physical exam and our review of labs, we have to remember that MASLD is a diagnosis of exclusion. And even though we have all this information, we need to go back to basics and do a very good history and workup. We need to talk to him about any other medications that he was taking previously. Perhaps he was taking something that can cause a lot of steatosis. And some of these things are like amiodarone and valproic acid that can lead somebody to develop fat in the liver. Also, was he exposed to any viral hepatitis like hepatitis C? Or did he have recent surgery? Post-Whipple patients can sometimes develop steatosis very quickly. The other thing we want to do is we want to definitely look at any other causes of steatosis, and we would check for hemochromatosis, we would check for celiac disease, we would, check for any autoimmune hepatitis. So all of that is done, and we even sent a PEth, and that was negative. So we definitely don't have any causes of steatosis, any other causes of steatosis. And we did get an ultrasound of the abdomen to look at his liver. Now, ultrasounds are not highly specific or highly sensitive, but they are a really good place to start to look at the liver because they're accessible and they're not very expensive. We did get a ultrasound on him, and when it came back, what we found was that the contour of the liver is smooth, which tells me that there is no cirrhosis. And there was definitely a steatosis present, and there was no signs of portal hypertension. So we know that there is no cirrhosis, so it's very unlikely that he's at stage 4 fibrosis. And we know that he definitely has steatosis, but if the ultrasound caught it, it's most likely moderate to severe steatosis in the liver. If it's very mild steatosis, an ultrasound will not show you that. So with all that information, we can kind of go down our line on an algorithm and confidently now state that, yes, we have a steatotic liver. That is the first criteria that we have to meet, right? And then we go through our cardio risk factors, and we see that he actually meets 3 of them. So he definitely meets the second stage of that diagnosis. And then we've looked at all the other causes, and we realized that he does not have any of the other causes of steatosis. So we can now confidently diagnose him with MASLD. Once we have that answer, the more important question comes up, right? And we have to answer a couple things. And the most important of these questions is, does this patient have any fibrosis? Because we still don't know that. We have an idea that he doesn't have stage 4 because there's no cirrhosis. And but we really don't know if he's at stage 1, 2, or 3 of fibrosis, and we need to find that out. Like I said previously, ways to do that is doing the FIB-4 test, or if that's not enough, doing an ELF test. If none of those are congruent, let's say you have a FIB-4 that is very low, but then you have an elastography that is very high and they're not matching, this is the time that you would want to send him for a liver biopsy to get definitive answers on what's going on and what stage of fibrosis it is, because that will depend on how he is treated. Again, it could be that we're just going to monitor for a year or two, or it could be that he needs to be sent directly to hepatology to evaluate for transplantation, or it could be anywhere in between, which would mean that he has the opportunity to regress his disease process by lifestyle modifications and pharmacotherapy. And with that, I want to end the education session, and thank you to GHAPP and Madrigal for the community network on MASLD and NASH. And thank you for being here.